So first, the corny song that is Mo's doing.
It was last second.
There's twice I've asked Mo to do a song, and both times it's corny.
I was put on last second, so.
And I. You're good with dogs, Chris? You don't mind dogs?
No, not at all.
Do you have dogs? How many?
I have one.
What kind of dog?
She is a mini Labradoodle.
So Buddy is half lab, half poodle.
Yeah. She's tinier. She was supposed to be 30 pounds. She's like 18. She's like this big.
I try not to have prejudices, and I try not to be judgmental. It's like I actually pride myself. I think I'm very kind of, give people a chance. The one place I'm like very archaic. If I never met you and you're like, I'm a cat person, I immediately write you off.
Yeah.
Like I just can't get past that. And if you're like a dog person, you could be like, listen, sometimes, I yell at my kids and I like do inappropriate. I'm like, yeah, but you're a dog person. It's okay.
I feel like people who only love cats, like their justification is, well, it's just like a dog. That's like their okay phrase.
Right. That's a good point. Now, probably one of our favorite team members, her name's Katie. She's like the fashion guru on the team. She like stylizes everybody. She's a cat person. But other than that, they're all weirdos.
So Katie gets the exception.
Katie always gets the exception.
Yeah.
All right. So this is a unique guest because I've known Chris longer than he's known me. And what I mean by that is my dad was like a doctor when his dad was starting off, and then they became very close friends and close colleagues. And as my dad retired and Dr. Rick Pumill, the venerable Dr. Rick Pumill, became I don't want to say an elder statement because he's pretty jacked, he'll kick my ass, but became a more senior member of the medical community. New Jersey, Mount Sinai. He's a very, very kind of prominent cardiologist. Then his son, Chris, followed in his footsteps. And now Chris is not even like the new young cardiologist, but the reason we wanted to have Chris on is a lot of our members, a lot of our colleagues, a lot of our adult primary care doctors speak very, very highly of Chris. And there's only a handful of really strong cardiologists that we use, and Chris is among them. And so a couple of my colleagues said, you have to have Chris on. He's awesome. We had an excellent cardiologist on earlier when we started. So the bar is high.
I'll do my best.
Yeah. But he's awesome. He's a great kid. Not kid now. He's a great guy. And I've known him since he was very, very young. And as always, we want to start off with the journey, right? And you could ask Mo.
Yep.
We've been doing this for like a year or so. And in the beginning, it was just like hardcore medicine and facts. And I realized as I've done it, not that we've drifted from that. I think that's the core of it. It's like wellness, healthcare, stuff that you don't get at your doctor's office and you don't get in the media, like pertinent, practical healthcare tips. That's holistic, that's non-aggressive, but very useful, right? And the reason we do this, just as a reminder, is, actually today, this was a good segue. Today, I don't do many of these, but I did it because there's a member, we take care of their family, and I just love them. They're the nicest people in the world. How many times do we get asked to go speak at schools and stuff?
All the time.
All the time. In 15 years, it's only the second time I've done it. And we get asked once a day.
Easily.
Okay. So this family's awesome. So she's like the lead counselor or whatever at the Patterson, I'm going to screw up the name, the Patterson Charter School for Science and Technology.
Okay.
And it's like these gifted kids and, charter school in Patterson. And so today, the whole morning, I was there, and it was career day, and we were talking. And these are really bright kids, and there was like honors classes, freshmen, high school, that kind of stuff. And I was talking to them, and I said this to them. I said, in the course of conversation, and when you're talking to smart people, you know why I like talking to smart people? Because they bring out better versions of you than you knew. Because when they ask smart questions, they challenge you to think in a way you wouldn't think when you're sitting there or talking to somebody else. And that thinking leads you to new, deeper conclusions. And so these kids were talking about why this, why that, whatever. And I found myself, I said, we have more healthcare than ever before. We spend more money on healthcare, right? It's almost, when you combine all the dollars, when you look at the gross domestic product chart and the national budget, it's a little misleading. They say we spend 25% here, 20. When you add up what we spend on health and Medicare and Medicaid, it's almost 50 cents of every dollar in this country spent on healthcare. And the United States, I just read this statistic. The United States spends 25% of the entire world's budget, healthcare budget. 25% is spent in the United States. And we have literally middle of the pack outcomes. Many, not a few third world countries have better outcomes than us. So there's more healthcare, more doctors, more specialists, more blah, 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 and yet more disease than ever before, right? We have more brilliant cardiologists than ever, but more cardiac disease than ever, diabetes and stuff. And so what we started to do, at Baker Health and through this is, well, if there's all this traditional doctor hospital more than ever, there's no shortage of that. And then everybody could go on social media where there's a lot of misinformation. Can we thread the needle? Can we get healthcare experts who kind of think outside the box and can marry the good of old school healthcare with some of the new stuff and try to explain why there's so much healthcare, but so little healthcare, right? Yeah. And so that's kind of where we're at. And so as we've done this, we've gotten some really cool guests, a couple boring ones, but mostly cool guests, right? Well, we're like 2 out of 3, we're good.
Yeah.
Is that fair? I'm not going to name names, but 2 out of 3.
Yeah.
Okay. So, I find that where we get the best feedback is where there's great information, but a great journey. And I don't think it's a personal journey. I don't think it's a coincidence. I think what I've learned is the folks that end up doing what they're doing through some weird path, through some inspiration, through something that's unique to them, not just because, I did this because I did that and then I did that, but through something personal, they bring that unique passion to what they do. And then, it emanates and it's refreshing and it sticks and it's passionate. And that's what people want, right? People could read they could read what we say, but if the right person says it the right way, it sticks in a certain way. And so if you don't mind, can you spend a few minutes talking about your journey and how you got to where you are before we get into the questions? Because there's going to be a million questions.
Yes, sure. First, thanks for having me and for the introduction. I was in a unique position because my dad was a doctor, so I was going to do everything in my power to not be a doctor because I didn't want to be a cliche. I'm sure you felt similarly in your life.
Very much, yeah.
And my dad was cool about it. He didn't push it, so I really had the opportunity to explore what I wanted to do and what kind of fit and what didn't. But in medicine, you have to start pretty early based on the interview process, things like that. So I remember through college, I was a bio major, and I was an okay student, and I had a good time, and, I enjoyed my classes. And then something clicked. I don't know. I just became much more interested. I realized what I needed to do. I became a much better student and started to sacrifice a lot more. I know we met when I was in college, I think, because you coached me how to go to a med school interview.
Yeah.
And I think what it ended up being was how I liked people. So people go into medicine to do all this cool stuff to people. I did it because I like to talk to people. So, I get to talk to 30 people a day from, somebody who is the CEO of whatever to somebody who drives the CEO of whatever. And I am able to relate to all of them. And that's kind of what I think fell into it for me. I stayed around here for college. I stayed around here for med school. I was at Rutgers. I went to North Carolina for residency because I decided I needed to get out of New Jersey for a little bit. I met my beautiful wife there, graduated, came up here for fellowship, and then haven't really left.
That's awesome. And can you speak to, when you say fellowship, what specialty you do and what translate that into English on a practical basis?
Yeah, so I did a cardiology fellowship, which is essentially of the heart. Within cardiology, you could do a lot of things. You could go to the interventional route where people would put in stents in arteries. You could do a structural route where this new developing field where they start to replace heart valves actually with arterial access instead of chest wall surgery and things like that. But there was a lot of temptation to go in a bunch of different ways. But again, I realized how much I like to talk to people. A lot of those people are great doctors, great people. A lot of them are my good friends. But you see people once or twice and you never see them again. And I kind of missed that, being able to see people every once in a while, to grow with them, not even just watch them grow. I think you grow as a person and the way you approach them. So I stayed as a general cardiologist. So I do a lot of blood pressure. I do a lot of valvular disease. And then a growing thing that I've started to learn, which they don't really teach you in fellowship, but something you kind of fall into yourself, is prevention. And I do a lot of pregnancy, a lot of cardiology and pregnancy. And I think that a lot of it is just based on where we are. So in this area, a lot of people, both male and female, predominantly women, are much more accomplished in their fields. They're working a lot longer. They're going to a lot more schooling. So they end up getting a little bit older when they have kids. And once you get to a certain age, they generally become high risk, which I think is a ridiculous term. I call it higher risk. I don't think it's very fair. And a lot of them come down my door. So that's really exciting. So do a lot of hypertension in pregnancy, a lot of preeclampsia, eclampsia, things like that.
Yeah,
so it's
that's
exciting.
an overlap. When I used to be in the children's hospital, I would be called when like a mom's preeclamptic because she might go early, so they'd have peds on standby, yada yada yada.
Yeah.
So I dealt with a lot of that back in my hospital days, which I don't miss that much. I wanted to, before we open it up, I wanted to pick a couple of things you mentioned. Sure. So the first thing is you talked about learning from your patients. And so I always tell people this. I think some people probably don't like to hear this. I think that if you tell a patient that you learn from other patients as their doctor, they might lose a little confidence in you. They're like, what? Didn't you get like 30 Ivy League degree? Like, what are you talking about? And I think the smarter patients recognize that's the true sign of intelligence, is perpetual learning, right? And so I want people to, if you have a doctor and your doctor's curious and they're trying to learn from you, and you could get that sense, you get that vibe from the doctor. They're making eye contact, they're listening, they're asking you, and you feel they're very interested. That curiosity is a sign of a good doctor. When the doctor comes in and just tells you everything and walks out without asking as many questions of you as you do of them, that for some people inspires confidence. To me, that inspires ignorance. And the reason for that, there's traditional paradigms in healthcare like CMEs. CMEs are continuing medical education credits. So to be board certified, we have to prove every year, every 2 years, every whatever, that we're up to date with the most current medical information. For those of you that don't know, we know in healthcare, 30% of what you learn when you graduate medical school, 3 years later, is no longer applicable, is null and void because of how much information changes. If you do the math, within a decade, most of what you were taught is no longer applicable. So in cardiology, statins help you, statins don't. There's side effects, switch this is better. Hey, the best way to lose weight is diet. Actually, the best way to lose weight is this revolutionary GLP-1s. Now, most people, healthcare changes by the minute. And so how does the medical societies know that we're abreast with things? Board certification. How do we get board certified? We have to do tests and quizzes and stuff to prove to societies that we're abreast of it. About 80% of doctors are board certified at any point, 20% are not. And I mention that not so that you know about our boring education curriculum, but so that you recognize ongoing learning in anything, not just as a doctor. Lawyers do this, accountants do this, everybody does this. I was talking to my friend who's in LA and he does like media. And he was telling me, he's like, yeah, I just learned how to do this AI script, thing. And I'm like, what? Like technology? He's not like a tech guy. And he was talking about this. He's like, yeah, I went on LinkedIn and I took this course and I got this certificate. And so any field has ongoing education. The question is, do you embark on it? I would submit, like what Chris is saying, that the best ongoing education for a doctor is their interactions with patients. And every single day I learn stuff from my patients. Like my Indian patients taught me very early in my career, you shouldn't avoid spices in an infant. We'd say, yeah, don't have salt or spices. For years, that's how we were trained. Turns out we've learned spices, like Far East Asian spices, have antioxidants, turmeric, have anti-cancer properties. And there's no reason not to give them to children and develop that taste. They're very healthy. I learned that from certain people. Massages from my Asian patients. We say, don't use oils on babies and scents and blah, blah, blah. Turns out massages increase circulation and babies can't walk. And so it's a good way to propagate circulation to their limbs and so on and so forth. And over the years, if I look at the advice I give today versus before, it's very different. Some of it's different because of medical advancement. A lot of it's different because of what I've learned from my patients. And so I wanted to call that out. The second thing is a question. You kind of just threw it away. You're like, I do hypertension, I do valvular, and I'm big on prevention. And you don't hear the word prevention from specialists a lot. So can you comment a little bit about that?
Yeah, cardiology is changing. You know, traditionally, medicine first made all its money, and not us, but the field itself, on fixing things. So putting a stent in an artery, replacing a heart valve. These are $100,000 operations, right? Brain surgery. And hospitals love that. Healthcare environments love that. But the truth is, if you can make, and there's certain things that will inevitably happen, right? And that's life. But especially in cardiology, a lot of it is acquired disease. We deal with some congenital things, and we can talk about that eventually. But the reality is, a lot of what we do is treating acquired things. So dietary changes, ways people approach food from young, and it's a compounding. So it's like whenever you're in college, right, they tell you to invest in a Roth because there's a thing called compounding interest, right? So if you live your life and you're extremely healthy, and then when you're 85 years old, you say, listen, I'm 85, I want to eat what I want to smoke a cigarette, I want to live my life. The chance of that causing something down the line is much smaller than if you develop an unhealthy health lifestyle when you're 18 years old. And even if it's not dramatic, those changes. So the same is the opposite, right? If you can reel in some of people's bad habits or change their approach to food or change their approach to how they enjoy a sweet, whether it be all the time or just maybe it's something special, there's compounding interest on the course of someone's life, which dramatically reduces the development of those diseases. Now it's starting to become rewarded in the healthcare world. But even beyond that, I think, you know, instead of starting someone on a medicine when they're 40 years old, I'd rather have a conversation when they're in their early 20s. Maybe we can prevent them from even needing a medicine, needing a procedure, or even pushing it back 20 years. So that's an exciting field. I think, me personally, I'm heavily invested in it. I think the healthcare literature is moving towards it as well. But I think that is the paradigm shift in what we do as cardiologists. Because I think that if I do my job early on, you won't need me later on.
So you spend time, like if you get a 45-year-old guy or gal who's in good shape or whatever, but they're creeping up on hypertension, you'll spend a fair amount talking about diet and exercise.
Yeah.
Okay.
And even if you it's even about just making small changes early on. And, you know, somebody who has to make all these huge changes when they're 65 years old, it's very hard to do. But when you start earlier and maybe you lose a few pounds a year. If someone's got 10 pounds to lose and you get them to lose 1 to 2 pounds, 1 pound a month, you know, so essentially what I'm trying to say is once you start about prevention, the rush. So my job, right, when people come in with crushing chest pain and, you know, heart attacks, you really have to move quickly. You diagnose quickly, you treat quickly. It's very aggressive. You got to wear a different hat when you do prevention because I'm not trying to light a fire under somebody or try to scare somebody. But if you can make these small changes and they come back to you in 3-6 months, they haven't made the changes yet, but you continue to coach them, continue to work through it. If they make those changes and they lose that 1 pound a month over the course of 10, 20, 30 months, that's way more of an impact on the course of their life than I could do even by, let's say, being impatient and starting a medicine the first time I meet them. So it's a little bit of patience and a little bit of just not causing any alarm, but pushing the patient to do it themselves, which I think is very rewarding.
I have a question about that. So when I deal with kids, I have families where the kids may be starting to show some signs of obesity or hypertension or hyperglycemia, the A1C's at like 5.7, some acanthosis nigricans, and let's say it's a 14, 15-year-old. And so you're starting to see early insulin resistance, early obesity, early hypertension. And we weren't hip to these things before, now we are. In my world, I learned this from like the best pediatricians that I was under, my dad and others, where what you say to, I think it's not just to a patient, I think in life, what, you know, to your wife, to your friends, I think what I learned is what you say is a distant second to how you say it. And so I've learned over the years how to try to be as effective as possible in communicating, because what I find when it comes to those kinds of things, which are important, people already know what you're telling them. And so the trick is they don't need me or you to tell them to stop smoking. They don't need me and you to tell them don't eat Oreos every day. They don't like that. That's not news to them. Like when you and me tell them, hey, the chest X-ray show, blah, 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 that's news. They don't know that without you and me. The ironic thing is the most important thing for their health, they already know. And the stuff that could have prevented them from coming to the doctor, they already know, but it hasn't sunk in. And so it's the how, not the what. Sometimes we're successful, sometimes we're not. In my position, it's somewhat unique because I'm talking about the kid, and I know when I'm talking about the kid, and Mo knows this, I'm really talking to the family because my 13-year-old in that exam room doesn't have a car, doesn't have a job, and he's only eating McDonald's because mom's, well, Dr. Baker, he doesn't eat anything. I'm like, Mom, he clearly eats something. Yeah. Well, no, Dr. Baker, I only feed him that because, otherwise he won't eat anything. I'm like, okay, so I have to be like, well, do this, that. Yeah. So I'm fighting a two-front battle, right? I want to ask you, when you have, let's say, a semi-responsible adult who's 38 years old, who's a little overweight, who's starting to show those signs, is there what's your success rate? And pretend it's me. I'm a 38-year-old guy. I come in because my PCP sent me because they were worried about how high my blood pressure was. I'm spilling protein, my kidney, whatever. How do you get through to me effectively?
I think that's where you and I think very similarly. You can't right away. I don't think you can. And I told myself I wouldn't get preachy here, but the problem with healthcare is I walk in, the old school white coat, suit and tie docs that come in is like, do this, do that, and walk out the door. And now, but that was a different time. Now patients are able to look up all this data that we look up too. Maybe we interpret a little differently because we've done it for longer, but they have the same data we do. Yeah. And they can get overwhelmed in it. And the options, and they Google something, and then next thing you know, Instagram's giving them ads about weight loss and do this and do that. And they just need someone to help guide them. So and you can ask some of the people that I'm sure we share in common, they think I'm crazy because the first 5 minutes, maybe it's why I'm so late all the time, but the first 5 minutes, 10 minutes, I just talk about them, where they're from, what they do for a living, where they came from, what are their interests. Because I think you have to learn a little bit more about the person, because everybody, like you said, everybody knows that they should eat a little bit less, whatever they love, and exercise a little bit more. But maybe it's not feasible. Maybe they work nights and they got 2 kids at home. And so once you start to understand who they are as a person, right, you can give a little bit more tailored stuff. And often it's not even life-changing stuff, right? I mean, I had a guy not too long ago that his blood pressure was high. He was a pre-diabetic. And he's like, that's it. Like, I'm never eating pizza again. I'm never eating it again. I'm never eating again, doc. And I said, well, do you like pizza? He's like, I love pizza. It's my favorite thing in the world. I said, why would you not do your favorite thing? Yeah. And so we kind of talked about putting together an environment where he does it. Maybe he eats it maybe once or twice a month, or maybe once a week, but big, right? Instead of like this thing where he's shameful about it. Right. He goes out to dinner with his wife. They have a wonderful time. They pick a new pizza spot around New Jersey. They have a glass of wine and they enjoy it and they cherish it. And by doing that, you don't eat it all the time because you look forward to that one time. And it's like it's an event. It's not something you regret.
That's good advice.
So that's kind of an example of maybe we don't make headway the first time, but the point is if I can learn from that person to see how they tick, maybe in the next couple of weeks, or maybe they're not ready to lose weight. Maybe they're not ready to hear about it. But maybe we go through some of the data together and they see what their life is going to become. And then it just puts that seed and they start to get ready. Okay. And then the next time they're ready to hear about, they say, well, maybe I do eat a little bit more than I should. Or maybe I do, I try to eat healthy, but it's the snacking that kills me. And that's how.
Yeah. That's how great advice. That's great. Should we get into the questions?
Yeah, someone wanted to cite about this topic. They said, I also feel like as a patient, we are more receptive to hearing how and why to make changes to our lifestyles and stuff when we can relate to the doctors, feel like they truly are a part of our family. But yeah, we have a bunch of questions. We could start off with this one. Someone asked, do you think there's a tendency for cardios to keep a patient on meds, i.e. Eliquis, versus trying to wean patients off heart meds? Liability, fear, what is it?
It's a good question. I think that a lot of it, I don't think it's fear liability. I think, we eat liability all day. That's what we do. That's our job. I eat liability for breakfast, right? And I think, and not to get it, but things happen to patients, right? But if you're with them every step of the way, it's not about our liability. I think you don't want something bad to happen. So if somebody has atrial fibrillation, which I'm assuming that they're referring, they put on blood thinners to reduce the risk of stroke. So there are certain times where we come off blood thinners, but the data isn't very robust on it. They haven't studied it there's very good data on who should be put on a blood thinner, who's not. But there isn't as much data on when to stop. So a lot of it is preference. So I think that a lot of the younger doctors who are trained in the new blood thinner era, so Eliquis, Xarelto, things like that, which are much, much safer, are more prone to leave people on it, as opposed to the old school Coumadin era where a lot more bleeding events happen. But I think that goes back to our previous point where it's a conversation. Again, if I have a patient that comes up to me and say, listen, I don't want to be on the blood thinner anymore. I don't want to do it. I hate it. I'm scared of it. Every time I walk down the street, I'm afraid. And then we start to have a conversation. Maybe your risk is a little bit higher. Maybe it's not. Maybe you're willing to accept that risk because that's something that you really don't want to do. But I guess I won't belabor the point, but a lot of it is with AFib specifically, the data isn't there. And then when patients get better on meds, that's the real question. When do you come off of them?
Yeah, and I just want to add to what Chris said something, because the spirit of that question goes to a deeper point. So there's the specific clinical technical point, but the spirit of it is this like cloud that exists between patients and doctors. And you guys teach residents and stuff?
In the hospital,
Students?
I do.
Yeah. So we have to teach, we teach residents and whatever, students and all this. And they come out also having these concerns about liability. I mean, the first time they're signing a malpractice insurance check, they lose their shit. They can't believe. They're like, oh my God. Because in residency, you don't do that. The hospital pays for it. And all of a sudden they're like, what? Like 20 G's or whatever it is, like for malpractice. So it gets front of mind. And patients, I think, not all, I think many patients, not just liability, right? Is the doctor just doing this to cover his ass? That's basically the question. Not only that, it's this, is the doctor doing X for some reason other than my best interest? Now that could be liability, right? To cover themselves. It could be profiteering. I hear that all the time. When I go to dinners and if I'm going with my wife and her annoying friends to dinner and they don't know I'm a doctor yet, like it's a new friend or something like that, you hear these conversations all the time, right? You hear it in the news, blah, blah, blah. So is there some other reason that the doctor would do it? Very few doctors I know, very few act that way. Some do, but I think it's a very, very simple question. And I think smart patient, I shouldn't say that. Some patients ask directly this. You'll be like, it's a complicated situation. You're like, do this, don't do that, do this, don't do that. They're like, doc, if it was your kid. And I also know some doctors who don't like to answer personal questions. I think that's the most honest question. And I love that's my favorite question.
Yeah, me too.
Because then you know exactly where I stand. I say and many times I'm like, the patient's like, hey, I'm going to do this. I'm like, okay, that's fine. It's within the bounds of acceptable. It's not totally inappropriate. Would you do that, Dr. Baker? No, I wouldn't. Yeah. But you just said I can do that. I'm like, it's not, some things are wrong. That's not wrong. It's within the realm of whatever. I love steak. I can't be a vegan, but it's fine for you, right? Or your kid has this disease. They need a medicine. It's not fine not to take the medicine. There's a spectrum of you got to do something versus recommended, vitamins, these kinds of things. They're negotiations. And I think many patients these days, often wonder in their interaction with doctors, is he or she doing this for reason X? Meaning not because they think it's the best interest. And that comes, the deeper point is, it comes from this huge distrust in healthcare. Yeah. Huge distrust. Whether it was COVID, even before COVID, vaccines, hesitancy, all these stuff. Yeah. You mentioned the old school blood thinners. There's billion-dollar lawsuits that happened with all these cardiac drugs.
Yeah.
So when people read that in the paper, or they had a grandma who had a side effect and she had a fall and died because of it,
Yeah.
I understand why they had the skepticism. Here's the best advice I could give patients. It's true, doctors don't know everything. It's true, doctors get it wrong sometimes. It's also true that you have every right to ask your doctor direct questions and be confident they're doing it for the right reason. It's also true that if you do that, then your doctor will probably get it right a lot more than you will, and a lot more than he'll get it wrong. So while doctors don't have all the answers, if you trust your doctor and think they're coming from the right place, they generally have more answers than the Facebook group you're getting your information from. And both those things can be true. I can sit here and tell you, in 15 years, the way I practice medicine now is not going to be close to the way I practice medicine then. That can be true. It can also be true that the advice I give you today is better than the advice you're getting from your neighbor who thinks it's all conspiracy to, destroy your kid.
And I think that it all comes down to, on a lot of the social media groups, ironically we're using now, but a lot of it is we deal with personalized recommendations. So what happens is that person X has a very specific example that was either a bad outcome or not, and then they will generalize that to a group.
100%.
And then that person will take that, and then it will be very different with the recommendation you give to them, but it's because you're individualizing to that patient, not the one that had this. So I think
That's exactly right.
then it just kind of jumps down the road.
You're exactly right, because think about it. When you give advice to a patient, where's your advice coming from? It's coming from studies that are translated into guidelines. Well, what's the foundation of a study? Sample size. So the studies, if I told you I have a study, I want you to change your habits. You say, great, Z, you have a Harvard study that said do this, that. You'd look at it, and if you saw that the sample size was 2 patients, you throw it in the garbage. So we agree the sample size is important. The problem is a lot of patients use their neighbor or their cousin as a one-person sample size. So even on a scientific basis, I think your argument holds water, besides anecdote in real life. Should we go to the next? That was just one question?
Yeah, that was one question. Somebody asked, can you talk about cardiomyopathy and the severity of it?
Yeah, sure. So cardiomyopathy is a fascinating topic because it is so diverse. We break it down into 2 things, and then we further break those down into severity. So cardiomyopathy breaks down into 2 things. One of them is ischemic cardiomyopathy. So cardiomyopathy due to decreased blood flow to the heart, whether it be blockages in one of the vessels, maybe somebody had a big heart attack one day that wasn't recognized or not treated, and that left a big scar of the heart, so it's not squeezing strong enough. That's one. And you can see how prevalent it is because that's in its own. The other one is a non-ischemic cardiomyopathy. A non-ischemic cardiomyopathy is just the opposite. It's not due to a blockage of blood flow. And that's just a hodgepodge. It could be anything. Certain viruses, medication-induced, genetic. It could be environmental. It could be anything. So that's kind of our mentality, our kind of breakdown. Ischemic ones are treated one way. Non-ischemic ones are treated another way.
Do you want to just define cardiomyopathy?
Yeah, so cardiomyopathy is essentially a heart that is not working appropriately.
Really broad.
Traditionally, it used to be because it wasn't squeezing hard enough. So every time the heart pumps, traditionally it expels about 55 to 65% of the blood in the chamber with one squeeze. So that's our ejection fraction. So we would say an EF of 55 or 50 to 65 is essentially normal. So previously, it used to be if it was less than 50 or about less than 50, it would be a cardiomyopathy. That's changed a little bit now because now sometimes the heart doesn't relax as well, which is now growing, which is also a form of cardiomyopathy. But for the traditional sense, it's either due to blockages, no blockages, but other cause, and then we grade the severity based on how much the heart is squeezing. So generally, 45% and above, and then 35% to 45%, and less than 35%. And you're going to say, who cares? The reason that I care is because a lot of the studies are put into different amounts of heart squeezing and symptoms, and that helps us with types of therapy to offer, types of medicine to offer, and things like that.
Nice. This is a good question. Someone asked, what's the best diet i.e. Mediterranean, and thoughts on processed food, as well as the carnivore or keto diet?
Yeah, you guys are killing it. So these are great questions, and most of my day, to be honest. So it's difficult, and I know we'll probably touch on how intermittent fasting and that new study that came out showing that it actually might not be as healthy as we think, and I can give you my 2 cents on it. But it's very easy for me, or not in a doctor setting, but to tell a friend, oh, try this diet, try that diet. But in my world, when I'm sitting on the other side of the room from the patient, you have to be very careful the recommendations you give, because there has to be some data behind it, because we never know downstream, right? So we can only give what the data is behind. So my statement would be the only diet to ever show longevity, people live longer and healthier, is the Mediterranean diet. It was done years ago, and people were given essentially huge amounts of olive oil. They followed certain amount of diets, a certain amount of parameters, and it was shown that people live longer and healthier. It's the Mediterranean diet, which you can read the book, but the overall kind of gist is very, very rare red meat. It's much more white flaky fish, lean meat like chicken,
And very rare meaning infrequent.
yes, yeah, sorry, yeah, infrequent.
It's not like have a lot of rare
Yeah,
meat.
we'll get to the carnivore diet in a second. And then
Mo got excited.
yeah.
He's like, I'm gonna live until 200.
And then olive oil, not butter. So those kind of simple things are really the healthiest thing you can do. It didn't matter how much olive oil, really. Didn't really matter carbs, things like that. And then we start to get into, I guess, fad diets. And I don't want to insult them, because I think they're all important in other ways. But, you know, I could give you a diet of Milky Ways. And if I restricted the amount of Milky Ways I gave you, I could call it the Milky Way diet and you could lose weight. But it doesn't particularly mean it's a great diet for you. So my hesitancy with a lot of the new diets are that there's just not the data behind it. And I wish it could be, I'll give you an intermittent fasting and I'll give you not, and then we watch you for 6 months, see what happens. The problem is when you do diet, the lead time is very far. So you have to watch people for years, 10 years, 5 years, 15 years. So it just becomes a very expensive trial. It becomes, the sample sizes are huge. So they're just very hard to do. So that's why our data is very old on it. And usually my favorite diet to push to suggest or recommend is the Mediterranean diet.
I always knew my mom was up to something when she would rub olive oil on my chest.
There you go.
Special shout out, Dr. Davey said, "What's up, Chris?"
How are you?
This is a good question. Someone asked, "What are your thoughts on statins and their use in young people?"
Yeah, man, you guys are killing it. So that's $1 million question. Statins are very interesting because I would say, maybe not in the pediatric world, but in the adult world, SSRIs, which are depression meds, and statins should probably be in the drinking water. I think statins have saved more lives than almost anything we've done put together. But they are not without faults, and they are not without caveats. So the cholesterol goal for people is really changing all the time. If somebody has an event, has a heart attack, has a stroke, it's very easy. Honestly, my job is very easy. There are very clear defined goals of where I should push your cholesterol to. But in not that population, arguably where I spend most of my time in the prevention world, that is really kind of fluctuating. So if somebody's cholesterol is greater than a certain number, so their bad cholesterol LDL is greater than 190, we classify them as a genetic genetic high cholesterol. So we have very specific targets. So we would push or recommend, sometimes force, statins on these patients because we know they do better. Their risk of heart attack, stroke down the line is astronomical. By treating them, you can cut their risk more than in half. I mean, it's life-changing. In between is where it gets difficult. So in people who are younger, without events, so heart attack, strokes, etc., I often very aggressively push diet and exercise. And the reason is is because I firmly believe that even if they have to go on a medicine down the line, if they're not ready to do it, or they're not comfortable with it, or they don't really want to do it, they're going to have side effects. Whether they're real or not, whether it's a placebo, it doesn't matter, right? Patient's still not feeling good on it, and I don't care if it's real or not, it affects me. So I do everything in my power to get their diet changed and their lifestyle changed, to get their cholesterol as low as possible, because then I prove to them that they can do it or can't do it. I hope they can, but if they can't, then we start to talk about medicines. To answer your, I guess, viewers' question specifically, I think that between the ages of 20 to 40, I'm a lot more lenient with cholesterol levels. So I try not to start those patients on cholesterol medicines very early, because it's generally a lifelong medicine. When people get a little bit older, something I've been thinking about and using a lot more is a calcium score, which looks for early development of cholesterol around the arteries. And that gives me a little bit more time to say, oh, listen, you have no plaque there, or very low, or very, that's great. Maybe an LDL goal of less than 100, which we all like to push, might not, I don't know, maybe it's not individualized to you. Yours in the 120s, let's just leave it. Let's check it in a couple of years. I don't think we need to do it. Or we say, listen, you've developed some cholesterol. I know you're 130. That's not particularly that crazy high. But whatever that number is for you, it's too high, and we need to bring it down.
You mean correlating with the calcium score?
Yeah.
So can you define, because the calcium score is more recent,
Yeah.
can you define, there's a lot of adults who come to Baker Health, and I see this in the chat. I see it all the time, because that's my insight into the adult world, where they're like, hey, I just listened to this podcast, Dr. Allday or Dr. Mike, and I want to get a calcium score. Where do I go? We get that all the time in the chat.
Like 5-10 times a day.
So what is the calcium score, and how is it useful, and who should get it?
So a calcium score is really interesting with both the healthcare system in itself and kind of how times have changed. So traditionally, a calcium score used to be this pay-to-play kind of thing, I guess, if you let me use that term. Like, they would go to a clinic, and they'd say, I want to know what's wrong with me, and then they would pay X amount of money, and they would get a scan. It wasn't covered by insurance. There wasn't really any problems with them. It was just like a kind of a pan scan thing, right? And then they took a lot of that data and they started to put together calcium, which we'll talk about in a second. So calcium with regards to heart issues. That ended up becoming quite well correlated with events down the line and is actually recommended by the guidelines. So calcium scores are very, very easy to get. You can go to any imaging center. It's a low dose, non-contrasted CT scan of the chest, and it looks for calcium. And you're going to say, I thought this guy knew what he was talking about. I'm talking about cholesterol, and he's talking about calcium. And that's true. What happens is that your body is smart, and cholesterol is very sticky. So think of cholesterol like, I always mess it up. Which is the one when you walk on the street? Which is the one that's soft? Cement or concrete?
Cement is soft.
Cement?
Yeah.
So think of it like cement.
It gives.
Yeah, it gives. And when you walk through it, you're not paying attention, and you flick your foot, you could flick the cement, right? Think of that as flicking some cholesterol down further into the artery, causing a heart attack, right? Your body doesn't like that, clearly. So it will remodel that cholesterol and calcify it. Because calcium, think of it like concrete. You hit it with a hammer, it's not going anywhere. It shows that there's underlying disease. It shows that there's plaque. But that plaque is not going anywhere. It's stable plaque. That lights up like a Christmas tree on a CT scan. So if you want to see an entire cholesterol burden.
In your vessels, this is.
Yes.
Yeah.
If you're looking for like entire cholesterol burden, you have to use contrast, you have to use specialized study, and which we do, but that's a little bit more invasive and more intense. This just gives you an understanding of cholesterol. It's been correlated with events down the line. So if your calcium score is 0, the risk of you having a heart attack or a stroke or an event down the line is very, very small.
No matter your cholesterol?
No matter your cholesterol.
So the calcium score unto itself is more significant than the cholesterol?
Yes, kind of.
Meaning, if I have a high calcium score with a normal cholesterol, you're more concerned than if I have a high cholesterol with a normal calcium score?
Yes, with one caveat.
Okay.
Your age. So if you have a cholesterol of 190 and you're 38 years old, there's a good chance that your calcium score is going to be 0.
It hasn't had the time to.
Exactly. So you have to be careful at what age you send it.
I see.
And I have that conversation a couple times a week where people are like, oh, my uncle or my friend got it. How old's your uncle? 55, 60. Great test. How old are you? 38. Not a great test. Because just as it can give you a lot of information, and if you have a cholesterol of 150, 160, and your calcium score is 0, and you're 55, I'd say anywhere above 45, 47, right? And then I say, listen, I wouldn't treat it. Even though it's high, and even though it's red, and even though it's got a mark on it on the blood test, I wouldn't treat it because I want you to work on doing this yourself. Once you have plaque, unfortunately, it doesn't really matter how much you change your lifestyle and how much you eat because the cholesterol medicines in themselves reduce inflammation and increase the remodeling. So makes that makes the soft plaque become more stable.
Yeah.
So that's where it becomes a little bit tricky. But yes, a calcium score is tremendously helpful. The only problem is now it's not covered by insurance.
Oh, it's still not.
Which is ridiculous. But traditionally,
How about if the doctor has a clinical indication?
They don't care.
Doesn't matter.
but the problem is that, I have a list of places in my office of prices. They're generally between $75 to $100.
Okay.
I think they've gotten away with it. Insurance has gotten away with it because they're not that expensive. I'm not saying it's nothing, but they're not that expensive where many people don't get it because they can't afford it. So nobody's really like lobbying or pushing their insurance companies.
Right.
But that's the only negative. But I love it. I use it, I don't know, 5 times a day I send them.
And on just now I'm asking for us on a primary care basis, maybe the adult doctors, they already know this, but what's the stand? Like we check cholesterol every year, blah, blah, blah. When should the average Joe get his or her calcium?
If people have low cholesterol and they're not on a medicine, it's well controlled, they don't have a high cholesterol syndrome, I don't particularly think it's that necessary.
Okay. But once you have high cholesterol,
I would say around 40 to 50. I think it's a great test to get.
Okay.
And then if it's positive and you start someone on a medicine, you never check it again. Why? Because you remodel it. So your calcium score will go up because it's taking the plaque you can't see that's dangerous and solidifying it.
Right.
Some people say, it's kind of a joke now, but I think there's some studies coming out that you can almost judge how much a calcium score goes up based on how effective the cholesterol medicines are.
That's interesting.
I think it's kind of theory stage right now, but it's fascinating.
That's interesting.
If it's negative, and the cholesterol's still high and you're still like, all right, let's give it some time. Let's treat. I usually repeat 3 to 5 years.
Okay.
I'll give them 3 to 5 years because, listen, you're similar. I don't care if you lose 30 pounds in 2 months. I don't.
Yeah.
Anyone can do it, but can you keep it off?
Right.
So if they can keep that off, and they can stay healthy for 3 to 5 years, that's the change.
Yeah.
So I give people a lot of time to make the non-pharmacologic changes.
Nice.
Sorry, I know we went long.
No,
No,
it's
that's
okay.
beautiful.
Next question actually came from one of our students. They asked, can you talk about the value of no APO protein and the particular size of cholesterol versus the total number of cholesterol?
Yeah, that's a really good question, and one that I don't think anybody knows the answer to. So there are a lot of ways to fragment cholesterol. And traditionally, we have LDL cholesterol, which is low density, and HDL, which is high density. And conventionally we would say that LDL was the bad cholesterol, and this, I know I've been doing a lot of quotes, and HDL is the good cholesterol. And when people ask me this question, my example is that we think that it was good and bad. Turns out it doesn't really matter. There was a recent study that came out, I think 6 or 12 months ago, that was showing that they were looking at total cholesterol, whether it be from high LDL, high HDL, and no matter what the breakdown was, high cholesterol is essentially high cholesterol. So I don't look too much into it. There is some data looking into it, and which isn't out yet. Not that I know, but I'm not holding a secret. But these are some investigational things where they're seeing exactly the breakdown and stuff like that. But that's not really mainstream yet. I break it down into a couple extra. So when people see me, I will order a few extra cholesterol tests. One is lipoprotein A. They're all cholesterol, right? But it's another type. And apolipoprotein B. Why? If somebody has a borderline cholesterol, like we said, when they're in the 190s, right? You say, or the LDL's in the 190s, you say, okay, maybe, no, there's a genetic cause. Let's say they're in the 170s. It's high. Let's say they look like you. You exercise, you eat healthy, you take care of yourself, you're in the 170s. That's pretty high. Do I think that's your doing? I don't. I think it's genetic, but it doesn't really meet the criteria. So I will order these tests. If they are significantly elevated, it kind of pushes me towards saying there's more of a genetic component. Those happen to be more kind of genetically focused. So that's, if that answers the question, that's when I use some of the more specialized ones. Not sure, some of them are correlated with events and things like that, but the real reason I do it is to help me push the treat. Plus, there isn't really any target goals for those cholesterol numbers yet. It doesn't really matter. It's just more conceptual to me to say, okay, how much am I going to push diet and exercise to you?
Right.
There's going to be, I mean, I tell a lot of people they can eat lettuce till the day they die. They're going to die with high cholesterol because, hopefully not from it, but with it, because it's genetic. Yeah. And that helps me push that. And once people realize that it's not their fault, it's not their fault to have it, and it's not a failure to take a medicine. If someone, God forbid, has a malignancy, they're not thinking they're a failure for taking chemo. And someone has, diabetes or
right.
type 1 diabetes, they're not failing themselves. Your 15-year-old with type 1 diabetes didn't fail himself by getting an injection for insulin. So that's the mentality I try to put into my genetically high cholesterol patients, and those can help.
That's great. That's very helpful.
Does that make sense? I know.
Yeah.
Yeah.
I mean, I got 90% of it.
I have a two-part question here.
I'll try.
The question is, what is the genetic component of HCM? And then if you could define it. And then the second part is, are there any signs of HCM in children? How likely is it for a child to have HCM if a parent and grandparent have it?
Wow.
Deep question.
So, HCM stands for hypertrophic cardiomyopathy. And you know how here we go. So I was talking about cardiomyopathy, right? How it's when the heart isn't squeezing that well. Hypertrophic cardiomyopathy is the heart is squeezing essentially too well. So in the heart, you essentially have think of it like these structures, like these beams. And there's a little motor in between, right? And it turns on when you contract and it pulls it together and then it relaxes and it goes like this and it goes like this and it goes like this. So let's say the normal heart has, let's say 2, right? Hypertrophic cardiomyopathies, you have too many of them. So let's say you have, I don't know how I'm going to do this, but you have more and more strands than you should. So the heart is a lot thicker and the heart squeezes a lot stronger. And it can cause a couple of problems. So traditionally, one is it can have some scarring. And when the heart has scar, it has abnormal rhythms. So you can have arrhythmias. So dangerous ventricular rhythms from the bottom of the heart or from the top of the heart. So ventricular tachycardia, atrial fibrillation, etc. So that's one. The other is it can kind of squeeze so hard it closes in on itself. And when it does that, it makes it hard for the blood to go out through the aorta, the main blood vessel, so it can cause aneurysms. And it can actually cause you to pass out because the blood isn't going anywhere. So those are some of the problems that we see with hypertrophic cardiomyopathy. There is a strong genetic component, so there are some genes we can test. There are a couple that are very classic, and then there's a couple that are being associated that, every week we learn more and more about genetics. So the question is good, really good. So you say, what are the chances of developing? It's really hard to say because it can take a while to develop. So depending on the genotype or the type of gene you have, someone can develop hypertrophic cardiomyopathy at 15 with the gene. The other person can develop it at 26, 28, 30. So I think in the kid guidelines, I think it's every year you check an echo. I think I don't, but
and you could do genetics one time.
Yeah, and if the genetics are negative, you're good. Because the chance of developing it wild type or not genetically are very rare. So if it's in a family and there's a gene and the child doesn't have it, you essentially they're out of that pool, right? But if the gene is positive, I think you check frequently, maybe 1 to 2 years as a kid, and don't quote me on that. As an adult, it's 3 to 5 years. The exciting part about hypertrophic cardiomyopathy now is there's drugs to treat it. So a new drug came out in the last couple of years. It's called mavacamten. Casmios or something is the brand name. But essentially what it does is it blocks some of these. So instead of having this many, which I wish I had another finger. Oh, there we go. You essentially will have maybe this many now and then this many. And it's revolutionizing the treatment because once you develop it too much, you can't really go back. The heart will start to blow out and not squeeze as much at all anymore. So if you can treat this early, you can prevent almost all of the negative effects that come from it. So that's a really exciting thing in hypertrophic cardiomyopathy.
So for the parent knows they have HCM, right? They know. And typically there would be a genetic underpinning. They identify that gene and then you test the kids for that gene. The kids don't have the gene, they're done.
Done.
Meaning they don't have it.
Correct.
They have the gene, you test them periodically. Call it yearly or biannual. Okay. I think so for the parents, because now there's more awareness of this. So you have a lot more families coming in with this. I have a lot of parents who come in with this. And the funny thing, or I shouldn't say funny, the interesting thing is I'll ask the parents, I'm like, okay, cool. How was your genetic workup? And they're like, what are you talking about? That happens a lot. And they're like, well, my cardiologist told me I have it. And so, you know, they're monitoring me and they're checking me and they sent me to Sinai for this and they sent me to Columbia for that. I'm like, no, that's cool. But did you check what genetics it is? And then they're asking me about the kid. And I'm like, well, we need to kind of genome map it first. So I think that's something, at least anecdotally, that I'm seeing. It's not automatically happening. I don't know. When you guys diagnose it, do you tell them to get genetic testing or how does it work?
I just do it myself.
You just order the genetics.
The problem is that it is so, geneticists are so well, I guess I don't know very many geneticists, but it's just, the field is so small.
So you just order it.
Yeah. There's just not many, it could take a year and a half
through
to
like
see
a commercial
geneticist.
lab.
I just do it.
Like through LabCorp.
LabCorp will do it.
Okay.
Yeah, LabCorp do it.
What's the test order you order?
You're going to laugh at me. I go to LabCorp. I go to the
yeah.
physician directory. I type in hypertrophic, and then it'll give me. They give a whole gene panel.
No. That's what I would do.
So then and then there's a test number.
Yeah.
And then then they order it, and then it comes back.
Okay, cool.
The question is insurance.
See, I send to genetics.
Well, in peds, I think it's easier. It's hard to find adult genetics.
It's hard, yeah. But to be honest, I didn't think the commercial labs would do that testing. So the fact that they will,
now they are.
I'll just order it.
Yeah, now they are. Some of the more rare stuff. So aortopathy, like dilated aortas, will do it. Hypertrophic cardiomyopathy, dilated cardiomyopathies, stuff like that.
Right.
Factor the bleeding disorders.
That, yeah.
Nice. Last question, not last question, but this person had their last question. They said, when should I do vein ablation for varicose veins? Is it more cosmetic or does it benefit me medically?
Good question. I get a lot of women who ask me about that.
Yeah, really good question. My partners are going to hate me for this. We do veins and we probably get paid pretty well to do it. And I often tell people not to do it for a few caveats. If they're thinking about having children, like if some people do it in between their pregnancies, just because you had one fixed doesn't mean you're not going to have more. Right. So I don't touch it until after you're done having kids, because just the amount of increased venous pressure from having a bigger uterus is just going to cause them to happen again. So that's easy. Cosmetic is you can do cosmetic, especially like for the little spider veins and stuff, is really easy. Those predominantly are not covered by insurance. It's more of a cosmetic procedure. But then you come to venous insufficiency where, so essentially varicose veins are, so in your veins, you have valves in your veins. Not nearly as, maybe I'm biased, but not nearly as important as the valves in your heart. Your arteries are high pressure. So if you cut an artery, it's like, just like in the movies, right? It'll shoot blood. You cut a vein, it does not, it oozes. So you can easily push blood throughout the whole body, but veins a lot harder. So how do you get blood from the vein in your foot up to your heart? When you walk, the muscles contract the veins. It moves up to a segment, the valve closes, and then you walk around and it goes up to the next segment. It's kind of like the Panama Canal, right, with the things. Mm-hmm. So what happens is that the valve doesn't work, so they leak back down. So if there's a big enough vein and you have to be specific about the veins, you can fix them. So if you have ultrasound diagnosed insufficiency, so we look for the valves and we see how much it leaks, and it's bothering you. So a lot of people will feel fullness, hot, they'll feel pain, feel like they're walking around with like thick, like those remember those like weights that people used to use, like you feel like walking around with that
Swelling.
yeah, and those will often become much better. It's not nearly as cosmetic because you still will you can't get rid of all of them. So it's not as cosmetic, which is kind of, I guess, my point I'm trying to say. So you're not going to have, that's just not one vein ever, but you will feel much, much better. And for symptomatically, the symptoms will be much longer lasting than the cosmetic symptoms.
That's great.
Nice.
That's really good advice.
This is a good question. Someone asked, what are your thoughts on alcohol usage? And then they said vodka versus wine.
So,
Big vodka guy.
yeah, I think that you got to live your life, right? And I think that the secret is everything in moderation. So, technically, the guideline recommendations are less than 14 drinks in a week for males and less than 7 drinks in a week for females. That equals, I think, an ounce of alcohol, an ounce of hard liquor, a one standard beer size, which I think is 12 ounces, and then 4 to 6 ounces of red or white wine. So in the eyes of the establishment, they're equal. With regards to, are there certain benefits for others? Maybe. I think that the one thing you have to be careful with wine is that there's a heavy sugar content. So I know that all calories are similar, but I think there's a little bit more sugar in wine. So if you're trying to limit your sugar intake, I would be careful with wine and lean more towards some of the harder spirits. But it doesn't mean you could mix it with a Coke, because I feel like that kind of puts you back a few steps. But if that helps.
So Dr. Pumill said, booze it up.
Yeah. As long as it's less than 14 drinks in a week.
For the men.
For the men.
Someone asked, what's worse, vaping or cigarettes?
Yeah. You guys are asking great questions. So, again, we can only be confident in kind of the data that we have. So there's very, very good data that cigarettes are bad for you, right? They cause coronary disease, they cause aneurysms, they cause cancer, they cause a million things, right? But nicotine itself really isn't that. Okay, it's not the worst. It's not the worst part of the cigarette. I'm gonna say it's not that bad for you. It's not the worst part of the cigarette, right? It's the tar. It's all the other things. It's also the heat. So how hot a cigarette gets, they can get like what 600-800 degrees, and inhaling that kind of heat can also cause, right? So that from a cigarette, right? So then these vapes came out, and in the purest form, if you were, let's just be in a silo here, and I say I can find a perfectly safe way to inhale nicotine, that would be dramatically safer than a cigarette. Yeah. But it's not, because it comes usually in an oil, usually vitamin E, or like this like thick vitamin oil. So the problem is that we just don't know how safe those are or not. So to answer the question, probably almost anything is safer than cigarettes, but I wouldn't kind of be accurate if I said we just don't know yet. There is some push in the data to say, well, what if we use vaping as a way to come off cigarettes? And the data is mixed, predominantly because we don't know how safe the oils are, and you don't know where the oils are coming from, and you don't know, I mean, it could be a place in whatever part of the world that develops it. There's no safety standards. It could be, lead-laced vitamin E. You don't know. So that's the only problem. But if they could standardize it and study it, I think it would be a very helpful way to get people off cigarettes.
Nice. That's all the medical questions I have.
That was really good medical.
Yeah, very good medical.
See how smart the crowd. Yeah. We have a smart crowd.
Yeah.
So someone asked, what do you do in your free time? And when you say exercise, can you define how long and what type of exercises you should do?
Me personally, I'm barely hanging on, so I try my best to exercise. I don't have much free time anymore. I come here and we hang out. So
you drink 14 ounces.
Yeah, exactly. Just 14. We have a measuring cup. so there's different types of exercise. And traditionally people think about weightlifting as a type of exercise, which is, but it's very different. So when you exercise with regards to weightlifting, when you bear down or valsalva or hold your breath to push, it actually increases your blood pressure dramatically. They did some studies. I don't know how they got away with it, but they were putting arterial lines in bodybuilders and having them bench press, and their blood pressure going to 300 systolic.
Damn.
So huge numbers. So it's not
Safe.
I don't know. I guess it's hard to say, right? I mean, it doesn't feel safe, but I guess people do it. It's okay. But so, it's not without risk. So the best, from a heart perspective, the healthiest type of exercise is aerobic activity. So you get, in heart rate variability. So you get your heart rate up, then you recover a little bit or plateau, and then you get it up. And that kind of change will remodel the heart. So that generally is spinning, swimming, technically running, even though I don't like running, but not me personally. I think it's heavier on the joints, but that still counts. I'll be fair. 30 minutes at a time, 3 to 5 times a week is really the
Standard.
the standard. And there's a caveat though. So that's cardiovascular help. The one thing that we think about, and again, this is I guess something that keeps me up at night, right? You try to do something for benefit, but if you're not thinking about it fully, you could do harm. So in people who are a little bit older and female, there is really good evidence to show that light weightlifting, whether it be body weight or light weights, is really important for bone health. So to reduce the risk of osteoporosis. So I think it's really important for that as well. So whatever gets you the most fit, I mean, I think that at the end of the day, as long as you're not doing these high risk maneuvers and where you're bench pressing so much, I think just the fact of moving is very healthy.
Nice.
Someone asked me about 10,000 steps next.
Actually, next question I have.
Uh-huh.
So did you see Ice Cube's offer to Caitlin Clark?
Yeah.
Brilliant.
Brilliant.
What are your thoughts on it?
I thought it was a smart move.
Crazy. And
How much would she make in the WNBA?
like the max contract, I think, is like $450,000.
That's a great move.
He wanted it to be private.
Yeah.
Somehow it got out though. Yeah, I think that's it. I don't have any more questions.
That was great. Are you keeping up with the March Madness? You went to Duke.
Yeah.
You went to Duke?
So
They're playing. So there's like or no, it's not Duke. It's UNC in Arizona. There's like a interesting storyline. They used to have like this duo in the backcourt.
Yeah.
The duo split because of one of the guys did something with one of his girls.
Yeah.
So they're trying to Arizona and
Taylor's old this time.
UNC.
And Duke, who's Duke playing?
Duke's playing Houston.
Oh, they're gonna get whooped.
Yeah. My problem is that so my wife's from Charlotte, and everyone in her family went to NC State.
Okay.
So they're big NC State fans. So
That's the women's team, right? They're
Their
good?
women's team is good.
Yeah.
No, but
Their men's team's okay.
isn't the men's team in March Madness?
Is it still?
Did
Is it
they
still?
lose? No, I think they're playing.
No, you're right. They're still.
No, I
in.
think they're playing
They have that
tomorrow,
big guy,
'cause
that
I'm
big passer.
Yeah,
Yeah.
because I'm flying to Charlotte to watch the game with them
You're right.
tomorrow.
Oh yeah, they're
Yeah.
playing
Yeah.
Marquette.
So yes, I can't. I got to keep my Duke mouth shut when I go visit my in-laws.
But Duke whooped James Madison.
Yeah.
But I think Houston is the real deal.
Houston's real.
Yeah.
Duke's real too.
Duke's real. They're young.
they're
young.
up and down.
Yeah.
But
They got some 7-footers in there that can really
Yeah.
play.
And
And they
they're-
got some stud like freshman guards. and so on.
Jared McCain.
I stopped. I used to, when I was younger, I used to follow college basketball because the players would stay for 4 years. So now I don't have time but March Madness always stays awesome.
You know what it is? It's not that the players aren't staying for 4 years because I actually watched something the other day. It was actually Charles Barkley. He was like, these freshman players, they're not taking over college basketball anymore. It's because they're not providing value, and that's because the transfer portal. All these coaches are looking at these players. They're like, okay, who's gonna provide me more value? The guy who played 3 years or who's post grad and he's gonna give me 10 points off the bench,
Right.
or the freshman who I don't know.
Yeah, you're right.
So that's like it's the transfer portal. Like all college sports is messed up because of like NIL and stuff. Now.
I have a question for you.
Yeah.
He's a big Giants fan. I'm a big Giants fan. would you be very happy or not if the Giants got J.J. McCarthy?
I would. It's like Daniel Jones' second coming.
So that's what most Giants fans are saying. They're like, because there's
I don't-
whispers. There's whispers.
Did you
now.
see him in the national championship?
Yeah, yeah.
He threw the ball
Can I
11
say
times.
it now?
Yeah.
So I totally hear you. I get it. Blah 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 blah. I watched J.J. McCarthy because I have a lot of annoying Michigan fans in my
Yeah.
life. So I think he's going to be an awesome NFL quarterback, and I think he's the furthest thing away from Daniel Jones. I think he's a true winner. And sorry, Daniel Jones was a Duke guy, but like Duke football players, it never works.
Yeah.
But give me, I bet you. Remember, I said this. J.J. McCarthy in 3 to 4 years is going to be an All-Pro quarterback. He's just resourceful winner, just enough athleticism and a great arm. I think he just makes it happen. And when I hear what his teammates say about him,
Yeah.
like I think all the Giants fans are like exactly what you said. They're like, it's going to be one of these not like awesome quarterbacks.
Because like if you look at it, like because really there's talks that he's gonna go top 4 now.
top 4 quarterbacks.
Top 4.
Oh, top 4?
Yeah, like the Commanders want him. If you look at the other prospects, you got. I mean, Williams is going first.
He's going number 1.
But then you got. If you're giving me the option of either J.J. McCarthy, Jaden Daniels, or Drake May, either one of those 3,
Yeah,
I'll even take Michael Penix over him.
I get it, but that wasn't my question.
Yeah.
My question was if the Giants got him.
I mean, I
It
guess
depends.
I'd support him.
No, you're saying if they passed up on one of those guys, you wouldn't be happy. That's what
I
you're
wouldn't be happy, but
Yeah.
if they drafted him, I'd have to. I'd support him.
saying. So your downtime, what did you answer the downtime question?
Not very well.
So what do you like? What's you have like a Saturday afternoon off. What's happening? What are we doing? Hiking, watching basketball,
It depends.
cooking,
Well, you know,
raiding dad's wine collection.
I guess starting a practice, I spend 26 weeks in the hospital in the weekends.
Yeah.
So in between, I just try to stay healthy. I don't know. I have a spin bike that I bought when I was in Durham, and I loved it, like a road bike.
Yeah.
Now I come here and it's only half the year. I mean, you could go whenever there.
Yeah. Yeah.
So I have one, and then I tried a couple times. Put my life flash before my eyes on River Road and between the potholes and the drivers. So I'm
Next
trying.
time, swing by Baker Health on River Road.
Yeah,
Hop in.
I honestly, I'd be there in a stretcher if I tried on my bike.
Yeah.
But
Hey, thanks for doing this.
this is awesome.
We had a lot of fun.
Thanks for having me.
Hey, how great was this guy?
It was awesome.
Was I part
Right?
of the 2/3 or the 1/3?
2/3.
The elite of the elite.
Elite, yeah.
Yeah.
Well, it was a pleasure.
No, that was great, man. You have a special way of explaining things.
Well, I tried.
Even my dumbass was able to keep up. So thank you for doing this, man.
Don't be silly.
Love you, man. And say hi to Dad.
See you guys next week.